behalf of the research team led by our principal investigator, Andrea Whittaker, I would like to start by presenting the research that we conducted since 2021, and we finished in late 2022, looking into the social burdens of living with antimicrobial resistance infections. So first of all, would like to start with the context for our research. So the antimicrobial resistance occurs when the bacterial, virus, fungi, and parasite mutate over time and they no longer respond to the medicines used to treat them. According to the most recent statistics, there was 5 million deaths that are associated with bacterial AMR globally in 2019. And there is forecast that in less than 30 years, the deaths associated with AMR will climb up to 10 million across the world. And behind those statistics of mortality is even the greater burden of morbidity that leaving many people living with long-term chronic illness and disability. The situation has been declared as a global public health threat, requires the knowledge and attention from multiple disciplines and sectors in understanding and in forming the responses to address the issue. However, there is quite limited engagement from social science. And this is one of the main motivations that prompted us to form this particular research. So in our research, we attempted to answer 3 big questions. The first one is we want to explore how the experience of people who live with the chronic AMR. We wanted to understand how they interact with their healthcare providers during their illness journey, and especially we want to learn about the effects that the resistant infections have on their lives and that of their caregivers and family members. In this research, we took a qualitative approach. We recruited people across Australia via several channels. We had some people who contacted Dr. Jeremy Barr, who is also a team member in our research about phage therapy. We advertised about our research across various social media sites of the Centre to Impact AMR and the social media of our research team members. We also reach out to people on some network of people living with urinary tract infections and the National Amputee Network. By the end of 2022, we conducted in total of 12 interviews and with both survivors and their caregivers. So in total had 15 people. And all the interviews that we conducted were on Zoom or via Microsoft Teams, and we also conducted a few on the phone. At first, we planned that we could have some in-person interviews, but the first half of our research happened when we were all in lockdown in Melbourne. And then when we went to the second phase, the second stage of the research, we decided that we continue to do the virtual online interviews so that we could recruit people across various states in Australia. And in fact, we also interview some people who were based overseas at the time of our interview. So in our interview, we usually started with asking the people to recall the context of their diagnosis, how they found out about their resistant infection, how they accessed medical information, how they communicated with their caring teams, and if they traveled overseas to obtain any form of treatment. And the interview then went to about the topics of the impacts it had on their lives and on that of their family members. So in the next couple of slides, I will talk about the main findings that we had out of the interview data. Focusing on, we identify 6 major themes, and I will talk about the impacts that AMR had on the social life, the emotional and the physical impacts it had on the caregivers, and also the burdens that the survivors and their caregivers suffer from living with this resistant infection. And then Andrea will come next to talk about the rest, the remaining themes. The first theme that was notable across the interviews was the social impacts that the resistant infection had on the survivors. So they usually talked about prolonged and traumatic episodes that illness caused to their life that limited their ability to continue to work. And for many of them, this caused them the isolation from the social life and causing a lot of distress to the sufferers. And for many of the people we interviewed, the resistant infection often happened when they were in the hospitals treating for other conditions. So the infection happened, it added up to the social and psychological suffering of the patients. And in many cases, it's also reinforced the sense, the feeling of medical mistrust with the doctors with biomedicine at the hospital where they were receiving care at that time. And the experience of the infection has become something that dominates the sufferers' lives and disrupt their imagined future. As you can see on the screen, is the excerpt from one of the interviews we had with a young woman who had lived with urinary tract infection for almost 5 years at the time of our interview, since she was 19. And she reported that she had the excruciating pain almost every day that discouraged her to participate in the campus life that she really wanted to since she started college. And it also affected her romantic life as well. The infection do not only affect the patients themselves, but it created a lot of pressure and burdens on the family members and the main caregivers for those patients. We have 2 stories from the caregivers that we had a chance to interview. As you can see, the quotes that I put on the screen. One is from Carol, who is the only daughter to her 86-year-old mother, who lives in regional New South Wales. Carol lives in Canberra. So every month she had to transport her mother to and from regional New South Wales to Canberra, where the specialist, the infection disease specialist that is based, and it is a 3-hour drive, and it's really interfere with her role in at the management level in a big organization in Canberra. And she was talking about how disruptive the caregiving had caused to her work. And next to the story of Carol is we had an interview with Ben, whose wife has been living with a resistant infection for almost 10 years, and they had 2 young children under 10 years of age. And when in the middle of the interview, he became very emotional and could not keep his feelings, and told us about how worried he is about thinking about the future when the infection could not be cured, and his wife, the future of his wife and his family is putting under risk. For the patients, for the survivors that we interviewed, which is quite a common observation across all the interview, is the repeated and the aggressive treatment regimens that they had undergone. And even when they're covered by Medicare or some other health insurance, it still incur a significant economic cost to them when managing their infections. Another story is from John, 59 years old, who lives in Canberra, and he recalled how his ankle infection has sent him to the hospital over the last couple of years. So the ankle infection keep coming up, kept coming back, and he had a total of 18 procedures in the last couple of years, including washing out and cutting out the infected bones. And yeah, at the time of our interview, he was having the risk of having his leg amputated due to the infection. And for all of the people we participated in our research, they had to be on antibiotic use for a very long period of time. And not only in terms of time, but also the dose, at very aggressive dose. And because of that, they usually suffered a lot of side effects, ranging from headache to upset stomach. And as two of the women that I put the stories on the screen now, you can see from Lucy and Ellen. And it was not only the side effects of prolonged use of antibiotics, but also the inconvenience and the troubles of administering the daily use of, for example, when they had to use the intravenous antibiotics and could not do it at home without any help from the professional. And sometimes they have to carry the antibiotics with them every day. And they also had to rely on the professional nurse to come to their home to monitor that use every day. And is a common expression that we often recorded in our interviews, that when the participants share with us that I don't know what to do. So this is not only something that's shared by Lucy, one of the participants, but we heard that a lot in our interviews when they expressed about what they think about the uncertainty of the future that is lying ahead of them. So this is for my part. May I ask Andrea to come in, and she would share the remaining themes from our interviews. And yes, Andrea, are you there?
Yep, thank you, Trang. Okay, I'll just get my head out of the way now on my screen. Excellent. So what was really interesting is that although this is a study of people with chronic AMR infections, some of our informants admitted that they hadn't heard about antibiotic resistance, even though they'd been attended by infectious disease specialists for many years. And some of them had only really come across that term when they were reading our explanatory statement. So I thought this was quite interesting, and it is important for what we'll say towards the end as well about the difficulties in doing this research and the difficulties in this identity term of AMR survivors. Overall, as a group, many people didn't necessarily know the names of what was causing their infections. And over time, of course, their medical histories had become very complicated. And so often it was really difficult to disentangle what the original infections were, what later infections were, and what their current symptoms were caused by. in terms of their interactions with their medical providers, many had long-term interactions, but for some of them, they felt as though because their infections had become so long-term and they were constantly going back for help and seeking care, over time they'd become one of those too hard basket sort of cases. And one of our informants spoke about sort of micro expressions of contempt every time he ended up trying to bring up something else. So that was Peter, whose slides just come up now, and he essentially talked about that his chronic bacterial prostatitis had been so difficult and so long term. He said in a sense for those patients, they end up in a victimized state of mind, really negatively impacting upon their doctor-patient relationship, which of course, that relationship is crucial to them ever actually coming to some sort of way of chronically living with these infections in a positive manner. Another one, Sandy, was an Indigenous woman who we spoke to in Canberra, and she spoke about her use of alternative therapies as being something that she felt was more culturally appropriate. And so she'd integrate natural therapies into the treatment. And yet she got the sense that if she spoke about those therapies, she was just getting labelled as a bit of a troublemaker. And then in turn, this got interpreted by her as being labelled somehow as a defiant native. So she felt then it became racialised. So this partly, I think, reflects not only the complexity and the sort of levels of desperation that both the doctors and the patients end up feeling about these infections, but also just the sensitivities when you've got someone who is trying to deal with a chronic, long-term infection that probably started as something that they assumed would go away quickly, and instead it's become a whole incidents where they have to learn. There's a term I.O. Wahlberg uses of chronic living. They have to learn how to live a new type of life with this chronic infection and chronic disability. We have the next slide, please, Trang. Thanks. So as I mentioned, many of our informants were using what we call syncretic therapies. They were combining essentially often very heavy duty pharmaceuticals with complementary medicines, with dietary therapies, all in a sense of trying to strengthen what they saw would strengthen their immune system to help them deal not only with the infection, but also the side effects from their antibiotics and other pharmaceuticals. One person who asked for her real name to be used, Joanne Matthews, actually has become a little bit of an advocate for natural therapies. And she spoke about, although being initially a skeptic, finding a doctor who was involved in integrative medicine and using herbs and Chinese medicine, which she felt had helped her daughter recover from streptococcal infection and gastrointestinal reflux disease following that really well. So she was really keen to advocate for more research to be done in more natural, gentler sort of therapies that could complement the orthodox medicines treatments. But she's quite an exception. If we could have the next slide, please, Trang. She was quite an exception in our sample. Most people were so tied up with having to deal with their infections and find treatment and were tired and sick that they couldn't really be involved in advocacy as such. Those who were using alternative therapies, just like the woman that I mentioned earlier, they tend not to tell their doctors about them. So here's Jenny, who's a caregiver for her grandmother. And she spoke about the fact that her grandmother's really into homeopathy, and so she's taken all this homeopathic stuff at the same time as her other treatments for her UTIs. But she said, of course, we don't consult with the GPs or doctors about that because they just don't believe in these kinds of things. So it also really signals to this sense that patients are feeling as though their doctors will simply dismiss them as stupid, or put them down or reject them if they start to talk about any other treatments or complementary therapies which they're trying. So I think that's something that, you know, might be a message for treating physicians, that actually opening up those conversations might be useful all round to know what people are actually using. We have the next slide, please. One of the and this is a photo that's been sent in to us by one of our respondents. This is the use of another, I guess, non-orthodox in many Western countries, but orthodox in Eastern Europe, which is phage therapies. And a number of our patients had undergone sometimes very arduous journeys in trying to find out about phage therapies overseas, which aren't currently available in Australia or weren't currently available in a number of countries. And eventually, you know, some had success and some didn't. But I'll give you a couple of stories from that. So Jenny, oh no, not Jenny, sorry, Sandra. Sandra's 37 years old, so quite young, and she had a really bad nasal discharge for years, despite having had ENT surgery. And for the last 15 years, she's been taking ciprofloxacin, I'm probably saying that badly, in a low dose, and levofloxacin in low dose, to try to get on top of this. She eventually moved to Germany, and there she was diagnosed as having resistant Pseudomonas aeruginosa, which I'm sure many of you are familiar with, and Enterobacter cloacae infections in her nose. So she was hospitalized in Germany. They managed with the Enterobacter infection in 2020 to sort of clear that up successfully. But they recommended that she go and try phage therapy to combat her other infections. So she traveled, this is in Tbilisi, and this is the very famous Eliava Institute for Bacteriophages, Microbiology and Virology. And they've been using bacteriophages in research and in treatment since 1923. And so she travelled there, and she was given little bottles with standard phage therapies each morning and each evening. And she was also given a nebulizer to inhale phages twice a day. She then later, so she stayed there for 2 weeks, then went back to Germany and has continued her home treatments. And she's found that basically the infection's largely cleared up now. Likewise, another person who we spoke to, Albert, has a methicillin-resistant staphylococcus infection in his prostate. He also went there in 2018. Stayed for a fortnight. He was injected with phages every morning. However, after his return, that home administration of phages was really difficult to maintain. It was quite distressing for him. He brought back phages that required daily infections into the urethra and just couldn't do them successfully or properly or without enormous pain. And so he found that about 4 weeks later, the infection and problems came back. But he said, though, despite all of that, he then imported some phages again from Georgia in a gel form and followed also some further medications, and that he said his condition's quite stable at this point. So that's just a couple of stories of people using phages. A couple of people have been trying to import phages. And at the moment, this, however, is really quite expensive. So one specialist has ordered a phage sample specific for a pathogen for another one of our informants. And they said that's going to cost them about $4,000 out of pocket to get those phages. So if I could have the final few slides, please, Trang. Okay, so what I'd like to do now is just think about this term of AMR survivors, because, you know, the first thing that you'll have noticed in our presentation is that we had great difficulty recruiting people for this study. And that was partly because we weren't going through a clinician, to get a discrete clinical population, but rather we were trying to get people from within the broad public who might have a whole variety of things, but that had in common that they had a resistant infection. But the term AMR survivor, even the term AMR, is not really something that's an identity term that's readily adopted by the people in our study. And many of them had very little contact with other people with similar conditions. Some of the younger participants were in Facebook groups, which is how they found out about us, such as the Chronic UTI Survivors group. But many took just an observer role in those platforms rather than really being active participants in them. And as a whole, AMR survivors are largely invisible as a group. Now, in social science, we often talk about biosociality, and this is a term which is used to discuss groups of people who come together. It's around the identity politics around particular conditions. And so, we might talk about the biosocial group of breast cancer survivors, for instance, highly visible. There's a lot of advocacy, people recognise and will talk about themselves as breast cancer survivors. Likewise, we might think about people living with HIV as another classic biosocial group that's undertaken a lot of political advocacy and campaigns around that identity. But it's really difficult for people suffering from what are a range of very different types of infections to constitute such a biosocial group and necessarily see that they have anything in common. So it's difficult for someone who may have suffered an amputation because of an AMR infection to see that they have anything in common with someone who has bronchiostasis because of an AMR infection. And so people tend to identify in terms of either the sequelae of their infections or the original infection, rather than seeing themselves as having AMR in common as AMR survivors. But this term is one that the WHO is really pushing at the moment and trying to set up a campaign of peer AMR survivors to advocate around AMR. And I think for us, we think that that approach may be a bit problematic, particularly in countries like Australia, where there really isn't a population that necessarily view themselves as having, a common cause around AMR as yet. The nascent sort of Facebook groups and various groups that a couple of our informants had set up tend to trade what Rose talks about as a new informed ethics of the self, where they're discussing cures, they're discussing management issues, they're discussing which doctors to approach. Essentially, they're talking about how to live with a chronic infection, rather than undertaking any form of political advocacy, which is how the WHO would like to see this group of survivors activate, in terms of advocacy. So I think we'll leave it there because we're probably, we're just about on time. And if you've got any further questions, we'll have discussions now, but please feel free to get in touch with us as well. So thanks.